Okay, so our next diagnosis, celiac sprue or celiac disease. Gluten enteropathy or tropical sprue are other names for it. So this is usually hereditary in nature, and it does vary in how the symptoms manifest themselves. Okay, so sometimes you will have very severe symptoms, and sometimes they'll be mild, depending how severe the person has this. Basically what happens is they have a problem digesting the gliadin, which is the breakdown of gluten. Now, where is this located? What products have this?
Grains.
Yeah, bread-type products, flour, exactly, wheats, that's right. Thank you. That's everything. Melissa's got it, right? Wheat, rye, oats, and barley. So you think, okay, so it's basically bread and pasta maybe. That probably contains everything, right? What do you think? No. That's right. It really is everywhere. When you talk about even chicken products, many of the chicken products we get, many of the sausages we buy, many of the hot dogs you buy, all those things have fillers in them. Even chicken that you buy, a lot of that has fillers in it. Unless, you know, you're getting fresh chicken that was cut off of the, but if you're buying like patties, or even if you're just buying ones that come, you know, they have fillers in many of them. So gluten-free is something that's become, you know, gluten-free menus, gluten-free items, things that are packaged as gluten-free have become important. They can make pasta that is gluten-free. They can make pizzas that are gluten-free. But do not think of that when you're taking an exam, because I get people that'll say, oh yeah, well, I thought you meant the gluten-free. No. When you're reading the exam questions, you are reading it as items that would have gluten in it. Okay? So for example, if it says, you know, you're the nurse for a patient, and you're trying to educate the parent on healthy choices, which of these would be the best option for the child, you don't want to say, well, I picked the pizza because they make gluten-free pizzas. It didn't say gluten-free, and it's not going to say gluten-free, so take it at the face value is my point. Don't make the whole story to it. I think that's sometimes what trips people up, is that they were like, well, we do have things now that are gluten-free, or we do have this. Yes, but we're you know, just take it for what it is. So that's the point there. So again, it's a genetic abnormality. It runs in families, and the severity ranges, obviously. It's usually obvious. It's really not seen at birth. Why? Because the child does not have exposure to gluten products at birth. Okay, so it's not really seen until after they started to have exposure to gluten products, and even when they've first been exposed to the gluten product, what happens is it will break the actual gliadin that sits in the intestinal tract will break down the mucosa of the intestinal tract and cause lesions, which will over time cause severe gastroenteritis and pain. But that won't happen with the first exposure. So many times you'll find somebody who will say they have celiac disease, but yet they eat a piece of bread. And someone's saying, I don't get it. They just ate bread and they have celiac disease. How do they do that? Well, that's why. I mean, it's one of those things that it has to build up in the system. Okay, so if you have enough, especially for certain people. Now, some people are highly sensitive. But some, it's like if you have repeated exposure over time, and they know. So many people know how to manage it or how to handle it. So that's the thing. So what do they see? They see things like constipation or even diarrhea or even steatorrhea, because those lesions that form, that eat away at the mucosa. Personality changing, wasting syndrome, or basically we call like a failure to thrive, pain, extreme GI pain and vomiting. Other clinical manifestations. Well, the body starts to build up these anti-gliadin antibodies. Okay, kind of similar to what we talked about when you have strep, right? But this is against the gliadin that's not being broken down on its own. So the body has this immune response, which actually can cause breakdown of the mucosa. And biopsies of the small intestines usually form a diagnosis for this, although they are working on genetic testing for it also. Because it does run in families, they can now genetically test blood for it. They're getting close. Dietary-wise, we want to give high-protein, low-fat diets, because especially if they're in one of those, especially if they've just had a lot of gliadin, or if they've just had a lot of gluten products. Because what will happen is they almost get like a dumping syndrome with those lesions. So you want to avoid high-fat diets, rice, corn. A lot of things now, like when we do see pasta, it's made with cornmeal. And that's why it's gluten-free. So they can have rice, obviously, or corn.
So is this rice and corn you're talking about gluten-free rice or corn, or just a normal one?
No, right, normal rice and corn. So when you see products, like people have said to me before, how do they make bread that's gluten-free? Or how do you make, you don't see so much bread, but you see like pasta now that's gluten-free. Or even like they actually do have pizzas that are gluten-free. It's because they're making it with cornmeal. That has
corn
no,
normally doesn't have gluten.
corn has no gluten, that's right, and neither does rice. That's why they're able to have that.
The lesions in the stomach, is that caused by the gliadin sitting there, or is it caused by the antibodies?
The antibodies, again, that's right. So what happens is you have this gliadin that's sitting there and the antibodies go to attack it, it's not being digested properly, and it forms like breakdown of the mucosa, almost like affect, you know, they also affect the mucosal linings. And when you have a breakdown in that mucosa, you start to have a shift in fluids, you have a lot of pain, and you can have the diarrhea. So wheat, barley, rye, and oats, that's what you want to avoid. And that's it's really the only way. If they avoid those products, then you will not have those symptoms. And they do make, again, menus that help with that. Hypertrophic pyloric stenosis. Yes.
Gluten intolerance but not having the celiac disease?
What happens is people with gluten intolerance still have it, they just have a lesser form of it. She's asking if you have a gluten intolerance, it is still a form of celiac disease. It's just a milder version of it. That does not mean that that person's children or other family members won't have severe forms. And again, people manifest things differently and how they affect them. But chances are, if they took somebody with gluten intolerance and they tested their blood, which they're working on to genetically be able to see, they would see there would be a mutation there on that chromosome 6 that would actually show them that they have this. But how it manifests is different. Same thing when we talk about sickle cell with hematology. You will see there are variations on how people respond with sickle cell disease. Okay, some people have very severe sickle cell crisis they go into. And some people have milder versions of it. Some people are hospitalized, some people die from it. So, when we talk about some of these diseases, there are variations. Same thing with, again, when we get to hematology, we're going to talk about hemophilia. And again, that also ranges in how severe and what you can see with it. So a lot of these are similar to that in that way. Hypertrophic pyloric stenosis, what is this? Thelma. Nick. Romeo.
That's what I know. Come on, that's what we had. You remember that?
Did you guys have that? Who had that one? Oh, no, you guys had appendicitis after
We had it.
That's right.
It's an obstruction of the stenosis of the pyloric canal or sphincter.
Sphincter, exactly. So who has this? Who manifests it? Tells you right there, but
in general, males, because they have stronger muscles, they tend to have those developed muscles, and which would cause the problem.
That's absolutely right. So many times it's more seen in males, and it does have a congenital a genetic component, which means it runs in family. It's not congenital, I'm sorry, but it has a genetic component to it, which basically means that it runs in male sides of the families. Often you can see firstborn male. Sometimes you have two boys in a row, or male even brothers that can have it. It's not present at birth. That is the key here. It is not congenital. It's not present at birth. So they're born. The pyloric sphincter works fine. And then sometimes it happens in a couple of months. Sometimes it happens closer to a year of age. Usually it's all within that first year of age. They start to have what? Projectile vomiting. Like, ever see Exorcist? Right? Like that though, really. I mean, the parents will say that when they bring their child in, they're like, oh, and it's like, it's like really strong. Now, people say the book contradicts itself because it will say these infants do not have a failure to thrive. And then there's another part that says over time you will get a failure to thrive. What does that mean? Well, it means if you have a parent, like most parents when they have a young infant, who starts to have every time within a half an hour of eating this almost volatile projectile vomiting, they're going to pretty quickly come to the doctor's office. So most of these infants, when they present, do not have a failure to thrive because it's not like the parents wait so long. I mean, if you have a 3, 4, 5, 6, 7, 8 month old infant who every time you feed them has this forceful projectile vomiting, by the second or third feeding, you're pretty much going to the pediatrician. Right? So if they were left, then yes, they would eventually have a failure to thrive because they're not going to be able to sustain that. Do you see what I'm saying? Because they're not really taking in anything. But for purposes of when you first bring them in, you know, obviously if they're brought in within a reasonable time frame, 24, you know, they're not going to be, they're not going to have failure to thrive. Does that make sense? Because sometimes these things, with the way they're written, people think they're contradicting itself. What it's really saying is, initially there is not a failure to thrive. Failure to thrive occurs over time. It takes a while for even a small infant to become malnourished. I mean, it happens quickly, obviously, because they're not taking in fluids, but not like within the first 2 or 3 feedings. And most parents with young infants like that will not wait too long. If they can't take a feeding, they can't take the second feeding, they're calling the pediatrician up. My child has this severe vomiting, and they're not able to tolerate the 2 feedings I gave them, or 3 feedings, you know, whatever it is. So again, where is the pyloric opening or the pyloric stenosis? At the end of the stomach, before the duodenum. So what kind of vomitus, or what kind of emesis will you see?
Vomitus contains stomach content.
Yeah. Right. Very descriptive, but yes. Yes. No, it's food. It's actual, you're right, it's undigested food, because it usually occurs within a half an hour of the feeding. So it's the undigested food that's sitting there within a half an hour, when it should be moving through the gastric system and going through the stomach. It does not. And then they vomit it up. They even have some reverse peristalsis. Okay, and it's food-like. You know, it's very acidic. It actually can cause them to have a lot of coughing. They can possibly aspirate, obviously. These are infants you want to keep their heads up. Again, like the previous ones we talked about. Thank you. So they're usually a good eater. So like when you give them the formula or the breast milk or whatever it is, they're taking it because they're hungry, right? So they are hungry, but they have this regurgitation that leads to this projectile. It's non-bilious, which means there's no bile to it because obviously it hasn't gotten to the duodenum, so you're not going to have that. It's going to be acidic. It can even be blood tinged. Has anybody ever thought about why it would be blood tinged? Yes, it will irritate the upper airway, the upper GI tract, and can even be blood tinged. There can be irritability. And this is like so key when you think about NCLEX in your books, and I know you have those NCLEX books you use. The movable, palpable, olive-sized mass, right of the umbilicus. They love to throw that into an NCLEX question. Okay, so that's what you will actually see is a palpable, olive-sized mass to the right of the umbilicus. What is that? That's it. That's the hypertrophied sphincter. That's what you're feeling. The hypertrophied sphincter is olive-sized mass, right, of the umbilicus on the infant. That's where that is. So the peristaltic waves can actually move opposite or be reverse. They can have, over time, obviously, a failure to thrive, which can lead to weight loss. Dehydration, obviously, which can lead to a hemoconcentration. We talked about that, right? Because you're losing more of the actual fluid. The intravascular fluid that you would have, you're losing that. And that could actually make you have a hemoconcentration. And the plasma volume, when you're dehydrated, decreases, right? So then you actually can get an increase in the hematocrit hemoglobin. Increased hematocrit. Decreased number and volume of stools. Well, that would make sense, right? Because nothing's getting past the stomach, very little, so that would be decreased. And they are prone to the metabolic alkalosis, which we talked about before. Yeah. Because you're losing hydrochloric acid, which is actually acid in your body. So metabolically, you're going to change that balance. Does that make sense? Yeah. So what would be your respiratory compensation for a metabolic alkalosis?
Breathing slower.
That's right. Did everybody hear what Bill said? You would slow down your respirations. It would actually have a decrease in respirations. So if their normal pattern would be 30 to 60, and an infant with this comes in at 20, I might not jump right away and say, oh, I got to put them on, get them on some respiratory or see what's going on with their system. Because maybe I need to correct this, and that will then correct the respiratory. So sometimes they come in with a slightly lower respiratory rate, but we don't necessarily worry about that because we want to correct the metabolic alkalosis. Does that make sense? Because you're going to want to retain CO2, which is acid, right? So that's why they slow down their respiratory rate. So usually the diagnosis is done with an ultrasound or an upper GI series, they say. But you got to watch. A lot of times they do keep them with the ultrasound, and they do feel the palpable mass in the upper right quadrant in the umbilicus. They're kept NPO prior to surgery, and again, it's because they they're not able to move the food and fluids through. Prone